when one gets to third-line therapy, you've had OX-based therapy, you've had ERI-based therapy. You have a menu of things, and we spell this out for patients. Here's what you can do from here on. And you've got 2 approved drugs. You've got regorafenib and you've got TAS-102. You've got clinical trials which are out there, and these patients often go on to clinical trials because they're still pretty good shape. Their performance status is pretty good. And then you've got recycling of chemotherapy. So drugs that you stopped, usually this is oxaliplatin, not because it wasn't working, but because you were trying to avoid neurotoxicity. So you have a pretty good menu of choices. And docs all bring to the table and patients all bring to the table expectations, values, discussions about what they should do at that point. Where I have evolved over the last several years is to value the oral therapies, the TAS-102 and the regorafenib, and their survival advantage that they bring to patients. I'm a big clinical trials guy, don't get me wrong, and we're always looking for new things. But I also don't want to ignore the fact that these 2 medicines have survival advantage. I also want to emphasize that if you wait too long, then these drugs don't really work as well. So to me, this good performance status patient in the third-line setting is really an ideal patient to start on the approved drug approaches and then push off the clinical trial piece till the next line. In third-line metastatic cancer, patients were randomized in this clinical trial between placebo versus regorafenib at a full dose, 160 milligrams daily, in a 2-to-1 randomization. And the clinical trial was positive, thus the approval. So it improved overall survival and progression-free survival. And the toxicity was acceptable. And so it was brought forward. And it's really fascinating that this drug works because we don't really know how it works. It has a bunch of different targets, maybe as many as 19, one of which is sort of a VEGF angiogenesis target, but there are others as well. And we've been looking very hard for a biomarker to figure out who benefits and who doesn't, but despite lots of investment, time, and effort, we haven't figured that out yet. And so all comers, RAS, MSI, whatever you want to call it, they're eligible for this kind of treatment. And based on the randomized clinical trial, there is a survival advantage and a progression-free survival advantage. Dosing regorafenib is a hot debated topic out there. Standard dose, 160 milligrams, 4 pills once a day. A lot of people are dose modifying right from the beginning. I think the most common pattern is to start at 120, 3 pills a day, and then watch them weekly. Some will start at 80 and escalate. Some will start at 160 and come down. So I don't really care how you do it. I just think you need to recognize the need for monitoring. When regorafenib first came out, oral chemotherapy, we thought you could sort of start them and see them a month later, and that was the right thing to do. And that turns out not to be really the best way to go. You need to monitor these people maybe more closely than you're used to, even with chemotherapy. So most of us pick a dose, 80, 120, 160, watch them a week later. Go ahead, make sure you see them, do some labs on them, look at their liver functions. See them 1 week after that, because often it's in that window that the hand-foot will all of a sudden arise and come on fairly suddenly, so tender hands and feet. And just the process of seeing them is reassuring to the patient. It also emphasizes the need for them to be good stewards of their own toxicities, compliance, all of those things that you need to monitor with patients. Once you get to a dose and schedule, you can then opt out and see them once a month or so. So you can get there. But the first cycle, the first month, you want to really see them, I think, 3 weeks in a row, draw labs, look at their hands, modify any doses, hold for a day or two, this sort of thing. In terms of managing the toxicities, there's not a lot here other than dose that we've figured out. You can use good hand creams, urea-based hand creams help. Good time for a mani-pedi, even a podiatrist to remove calluses. Some people argue that that's a good idea. You have to remember the majority of your patients will tolerate 160 pretty well, but it's those ones that really don't, who come in their house slippers 2 weeks later, that you have to, wakes you up to the need to modify these doses. Liver function abnormalities, rare, but we watch and monitor for them in all patients. So get them through that initial time, figure out if they're in the half that benefits from initial therapy, and get them on a dose that you can continue long term. A drug like regorafenib, to clinicians, has taken us a while to sort of figure out its value. We want responses and CEAs dropping and this sort of thing. And stable disease is a little like kissing your sister. You know, it's okay, but we want more than that. I think our patients want more than that too. Over time, as my experience has increased with the medicine, as in fact I've shared with other folks who use a lot of the medicine, there are clearly patients who have long-term benefit. There is clearly a tail on the curve for some patients who have 12 months of stabilization. And it's very hard to predict who that patient was going to be. So I've seen it with big tumor burden and small tumor burden, young and old. And what we need is that biomarker to figure out who that's going to be. But until such time, we really, I think, are obligated for our patients. Are you one of these people on the curve where you're going to have long-term benefit? And find those patients and treat them. This patient has now had OX-based therapy, ERI-based therapy, now has had regorafenib therapy and progressed on that. Many of these patients will still have good performance status, still be eligible for more treatments. And it's in essence the same menu we talked about before of now you've got TAS-102 as an approved drug, you've got clinical trials which are out there, and you've got recycling of oxaliplatin. And I think you make your decision at this point based on the overall needs of the patient, how the disease is doing, eligibility for clinical trials, and the like. Don't forget the TAS-102 is out there, survival advantage as well with that. More of a myelosuppressive kind of drug, but one that can help patients as well. We do have in refractory setting 2 drugs approved, regorafenib and TAS-102. And because TAS came second, we actually have in their clinical trial patients who'd had Rego first. And so if you look at the subgroup analysis of the patients who'd had Rego first, there was still benefit from TAS as a fourth line, if you will, therapy. So we at least have that experience that one after the other is still a positive for patients.